everybody and thank you for Dr. Hisham in particular for inviting me. It's a great honor to I've worked with him over several years in various places, so it's always good to be reassociated with him and continue to be involved, I'm sure. Thank you for that great introduction. I don't think you need to say anything more. But I was just going to say is I'm not going to talk about all evidence in 2025 because there's so much I can talk about, and it's not enough for 20 minutes. But I will stick to one particular sort of favorite topic of mine, and that's sort of some of the newer things in cardiac arrest. In particular, I'll mention where I think transesophageal echocardiography during arrest, inter-arrest, has a place. So it won't replace a lot of stuff, but it definitely, in my view, has a place, and I'll try to explain that. And obviously, I can't talk about cardiac arrest in 20 minutes because you can see this book by Halperin, which I actually own, but it's 1,300 pages. So 20 minutes is not enough. But anyway, we will do what we can in less than that, hopefully. So the objectives of this talk is I'll just talk about a couple of the theories, because this has come up a couple of times in recent discussion with colleagues. And there seems to be a little bit of, I'll come to that. Is it a cardiac pump theory or is it a thoracic pump theory? And it doesn't seem that it's absolutely clear, but I'll come to that in a minute or in a few minutes. And then we'll talk about the role of echocardiography. I mentioned that. And also, can other modern technology improve outcomes? And I think that goes to a little bit of what Mohammed was saying in the last talk. And I'll mention a couple of that. Okay, so there's basically two theories, two main theories. There's multiple actually, which are going around. One is this cardiac pump theory, and that sort of assumes that compressions during CPR are actually compressing the heart between the sternum and the back of the vertebra, and causing ventricular sort of contraction and blood flow, and that sort of assumes that the valves are actually working. The AV valves close and open during compression, etc. On the other hand, you've got the thoracic pump theory, which I think a lot of people still believe in, and I think it does have a role, but they think that it's the only thing, and that assumes that the valves remain open and the heart is just a conduit. So the blood just flows through it because of the compression and of the chest, the whole chest, increase intrathoracic pressure, and then whether you do an active decompression or just a passive recoil for the blood to flow back. So those are the two theories, but on the top left, I don't want to dwell over theories, because there's also a lung pump theory, respiratory pump theory, a left atrial pump theory. I think as studies have gone by, people have looked at different equipment and tried to come up with reasons for it working. But I think the main two theories are still the ones I mentioned first. And there's different devices. Obviously, we all know about some mechanical devices. There's a piston device. I mean, I've used this. I don't want to mention names, but I've used the German one here. It's basically a thumper, but it is a very convenient thumper, because it's actually convenient in that you can take a patient to the cath lab with it, and the arm swivels, as opposed to the device below, the Lucas device, what we call it is, which is in fact, it's always not just a pure thumper, it's a combination device because of the suction on it. It tends to actively decompress, or is thought to. So it's not just purely a thumper device. But the problem is you can see that both arms get in the way of procedures. It gets away, particularly if you're taking a patient to cath lab on it, it gets away in the way of the C arm for imaging angiograms and stuff. And then, there is other ways which you can use active decompression devices with an impedance threshold valve. This is something I studied during my FCAM, FRCAM at the time. And again, all these devices are meant to, they come in to make it better, make the more effective, but in fact haven't shown outcome differences. And their main uses really are to make CPR more convenient, especially during transport. But they are costly as well. So what's the ultimate goal of CPR is to achieve critical perfusion of vital organs, while you can find a reversible cause or defibrillate the heart. So, it's if you're maintaining critical perfusion, and and also the coronary perfusion pressure, because if you can perfuse the coronary arteries of the heart, the theory is that you can defibrillate it back into a normal rhythm more successfully. But the thing is, nowadays there's people think that both mechanisms, the cardiac and the thoracic, contribute, and a single theory is unlikely to fully explain what happens. The problem is, early on, it's thought that early on it's probably the heart compression theory that works. Later on, as there's a biochemical change, and sodium and potassium, calcium move out of cells and things, then the heart becomes much less effective, and it may just be that the thoracic pump is what's working. So that's what people are thinking. It's very hard to prove one way or another, to be honest. And a lot can depend on the patient's habitus, body habitus, different types of compression forces, rates, the airway ventilation related issues, and also the delay. So as I said at the beginning, you get one aspect that seems to be more predominant, and the other one afterwards. And if you look over the series over the years, and I put them in two groups, the thoracic pump, those that supported the thoracic pump were mainly done in the 80s, if you can see. And in the 90s, most of them now have supported the cardiac pump, mainly because they're using more actually imaging. So it's not circumstantial evidence, it's actual visualizing the heart. And they think that the cardiac compression is a significant mechanism. And I'll come to the echo. So I'll go on to echocardiography as where that comes in. And where it comes in is, there's obvious advantages. It's not, in general, we're talking about echocardiography, I'm not talking about transesophageal here. So it will obviously identify patients with poor prognosis, i.e. those with asystole and cardiac standstill. So those guys, for a period, if they've had that for a period, the chances of them actually having ROSC is very low, unless there's an obvious reversible cause. And again, sometimes what can happen is what can look like an asystole can be actually a fine VF. And an echocardiogram can identify that, and you can go on and defibrillate. Or when I say echocardiogram, I just mean a point of care ultrasound, so of the heart. So I'm not actually talking a formal echocardiogram in that sense. But then what's definitely established is that echocardiogram is very useful, or ultrasound is very useful to identify obstructive pathologies in particular. So the 4 H's or 5 H's and 5 T's, depending on which number you use. But particularly when it's massive pulmonary embolism, a cardiac tamponade, or tension pneumothoraces. And also, as I think one of the ladies on the sepsis were talking about, hypovolemia can be diagnosed quite easily with cardiac echo, and also of the vascular system. And obviously the problem with normal echocardiography is it as we all know, if you've done them before, is that it can cause interruption to chest compressions, which is a bad thing. So the idea is that, okay, we're just going to record a loop of during the pulse check, and then observe it or watch it later on as we're as we continue chest compressions. But the problem is, again, the other problem is getting views externally can be quite difficult, because as we know that air can be in the stomach, it can as chest compressions go on, and also body habitus can make it difficult to get views. So the main advantages of transesophageal echo are, and the diagnostic role is the same, and these are endorsed by AHA ILCOR. So there isn't really that much debate about that, in my view. But the thing is, on the top bit, the enhancing CPR quality, because what it is, if you put in a transesophageal echo, you can continue chest compressions just as normal. And also, if you do believe, and like I do, in the heart pump theory, cardiac pump theory, then you can actually look at chest compression and see what effect it's actually having. Now, this is really interesting because we ran a course on echocardiography recently, a workshop, and and we had some experienced physicians, ER doctors, and they were like, okay, let's do an echocardiogram. and we had volunteers, and they couldn't really find, the good views because the volunteer we had was quite slim. He was a Bengali guy, porter or whatever, and his heart orientation was much more vertical. So his apex wasn't where you would expect it. And this is what one of the points I'm going to make is that everybody's slightly different, and doing compressions in the exact same way is unlikely to get the optimum effect. And I'll come to that in a minute. But the problem, obviously, the limitations of transvaginal echo is the probe. It's a separate probe. You need to get that. The actual screen and other ultrasound machines is probably the same. And obviously, the patient has to be intubated. And then this is also important. It's more people because the team leader role has to be separate from the person doing the echocardiogram. They have to communicate, but it can't be the same person, ideally. And obviously, to do these sort of quote unquote invasive procedures, you need buy-in from the institution. And you need higher level of interpretation skills. Not everybody's comfortable with this skill yet, but I think I personally think that it should be something we should be part of our competencies eventually. And I'll come to it why. The complications can happen. They're very low risk. As you can see, they're less than 0.1%. Overall, but the problem is that can be pre-existing pathology like stenoses or webs or whatever, and then the problem with that is sometimes in cardiac arrest, particularly, you don't have that history. So I'm just going to just show you one quick study, which is this one. In fact, everything I'm showing is 2025, so in that sense, I'm pretty much up to date. I'm trying to give you very current things. And this is one was published in Resuscitation in March this year, just a couple of months ago. And it was from Australia, and it's more an observational study, so you won't call it high quality data, but it is very interesting because the physician, they did pre-hospital transesophageal echo. Now, that's quite a challenge in my view, and it's something that I'm not quite sure, you can scale it easily. But that's what they did. And what they showed, if you look at this diagram on the left, you'll see that before they did adjustments, they were getting, in these 19 patients, only 3, in his view, were getting good compressions. In 6 of the patients, and 9 of the patients, actually, there was either left ventricular outflow tract obstruction or aortic root compression. So that means you're actually making it worse by compressing. And otherwise, in a few of them, it was ineffective. So only 3 patients, was there a good compression without the guidance of the echocardiogram or echocardiographer. And none of them, these patients, or almost none of them, had a brachial pulse. 16 of the 19 didn't have one. But after adjustment, you could see that the compression had improved significantly, and the pulse, you could feel a brachial pulse in all of the patients. Though there was some good outflow. Now, this didn't necessarily, the study was too small to show an impact on survival, but what it did show is that you can actually guide your CPR much better with and chest compressions also. A single mode of compressions isn't always the right answer. So you need to be able to adapt a little bit if you're not getting the right output. And that's something that we're not doing, I think, in my personal view. And you can see, though, it's a big team you need. So you need an echocardiographer, the lady who's in B, and then you need, and this is a big team for a reason, because other than having all the people who are supporting the CPR, you also have ENF, who are the ECMO team. So, if you're going to do eCPR, then, guiding while they're getting cannulations and stuff, then definitely echocardiogram may be useful in optimizing chest compressions and output. So just to mention, I mentioned competency and stuff. So, this guy, Philippe Terran, is the first author of this review article, and he runs a whole bunch of courses on doing exactly this. He thinks it's teachable to emergency physicians, and you can see most of these are in big conferences. So there's there was one in Montreal just before ISIM. There's one before ASAP, American College. There's another one coming up in September just before USIM. So these are associated with big conferences where he's teaching this skill. But and this is the problem. The problem is that if you look at it, the reason we're talking about this is that the overall out of hospital cardiac arrest survival is quite low. So it's well below usually 10%. For example, Sweden, which is quite an advanced country with a high CPR rate, it was only like. It improved from 5.7% to about 10% over like 20 years. But since then, it's remained unchanged. And so that's not very good, 10%, to be honest, if you think about it. And the US is the same, similar. Although it's better for in-hospital cardiac arrest, which is a bit counterintuitive because people in hospital are sicker. So you think that these guys, if they have a cardiac arrest, they do poorly. But overall, it's up to 22% survival in hospital. But what that shows to me is that it's all about time. In hospital, we're trained, we can recognize quickly, the team shows up. Out of hospital, these things don't happen that quickly. Now, this is interesting because this is from Minnesota, and I've put this picture here on purpose on the top left, which they actually have a patient reunion of cardiac arrest survivors. So this is their ECMO program. So you can see that when you look at this many people getting together in a room, and this is not all of them, and these are people who are essentially dead. So then you realize that having a good program and high survival rate is very important, or it's an important thing, because these are all people that look like they could easily be productive members of society or their families. So what happens here, and they showed in their group of 160 patients, you can see that the functional survival rate was about 40% down here. Yeah. So after they've excluded a few patients, but even if you don't exclude the patients that were excluded, some of them, and then it's even up to 30%, so still very good. But they've always excluded patients who didn't fit the criteria, or they just couldn't sustain their rhythm. But even with that, it's more than 30%. So where do I think this fits in? The echo and the ECMO. ECMO I think that's fairly standard now. It's not something that's, it's a must, but certainly if you can provide that standard of care, then I think the newest guidelines will show that then you should consider it. And I think there's a big trial going on they've stopped recruiting in Holland. They've done it over 3 years for pre-hospital ECMO, and they will come up with their results, and they will show. So hopefully it's very interesting to see what they actually show as far as survival in a country like Holland. So what I show is, okay, so for me, the most important bit is collapse and early recognition and good basic life support and defibrillation. And then, obviously you immediately get either your ROSC, and that's fine, you get good care, or you should get good care. Or if you haven't had ROSC, then you need to look at certain criteria, which are in the blue, in the green, and consider putting in cannula for ECMO. But in this period between ALS and your next leg is what this comes in. That's where you need to really optimize perfusion. If they fit the criteria, and you exclude all the reversible causes, and the best tool you have to do this is actually, or one of the tools, I won't say the only one, but I think the best tool is a transesophageal echo. Yeah. But I don't want to sort of bamboozle everybody with high-tech stuff, ECMO and all that stuff. The basics are still very important, or the most important. And this is, if you recognize Cliff Reed, one of my gurus. This was at a conference earlier this year in Spain, and what he was showing is that ventilation is still very important, because if you look for the first 120 seconds or so, 180 seconds, 2 or 3 minutes, 3 minutes, the saturations remain well preserved, even without any ventilation. Yeah, it's only after that you start dropping your saturation. And even with expired air ventilation, you can maintain some saturations, but if you don't give any, they drop very quickly afterwards. So you do need to, still, I know compression only CPR is a thing, but we do need to think about a good ventilation and good compressions. Now, obviously, as far as compression, there should be adequate. The depth, the rate, the excellent recoil, and minimizing interruptions are still the key. But I think my own personal view is that and I'll talk about this in the next couple of slides as far as where my technological solution to some of this is that in an out of hospital setting, time to recognition and activation are the key thing. Now, bystander CPR is a great thing. I mean, if you can teach all of your population and they're all keen to, do chest compressions, that's great. In the UAE, we've got a Good Samaritan law now, but still the responder CPR rate's very low. I think, my own personal preference is to have a whole bunch of first responders in the community who are trained, supported, motivated, and activated. Okay, you can have the bystander, but I don't think that's going to be and who have access to AEDs. So, and one solution for me, I mean, this is a study protocol for a study in Victoria in Australia. It's called FIRST protocol by the ambulance service. And this, they use a special AED, which actually is handheld. It's as big as a phone. And essentially, it's carried by the bystander, by the first responder. He snaps it, puts it on the chest, it peels the sticker, puts it on the chest, and it defibrillates. And instead of waiting for a defibrillator to arrive, that is, in my view, the way forward, this sort of thing. And then on top of that, what you could arm people with is AI tools, i.e. digital watch, smartwatch, which actually, using the gyroscope function in it, can tell you the rate and the depth of compression. So it can guide the person doing the chest compressions on, it's like a feedback device on their wrist. But at the same time, it can activate emergency services immediately. So, and on top of that, I mean, this is a study from China. This is my last slide.
I'm really sorry, Naeem.
Thank you. Yeah, I'm done.
Sorry.
No problem. This is my last slide. I'm done.
Thank you. That's your last slide. Okay.
Yeah, this is my last one. Sorry. So it just shows that basically you can actually have a digital watch actually detect your cardiac arrest and activate emergency services by itself. So, so this is the future. And in summary, what I'm saying is the basics is still really, really important. And what we need to do is somehow optimize the patients and get optimum chest compression using whatever tools we have, and then maybe go on to other things like eCPR if you have to. And that's it. Thank you. Sorry.